thyroid eye disease. It was published 2 months ago in Lancet, and actually it pulled data from two previous trials. One published in 2013, one in 2018, a phase 2 and phase 3 trial, and they just went on and did a pooled analysis. But before I proceed to the paper, I'm just going to just give a bit of background on thyroid or Graves Orbitopathy. We know that it is the major thyroid manifestation of play. It may not frequently occur in patients with chronic autoimmune thyroiditis. It is relatively rare, so the estimated incidence is 0.5 to 0.9 cases per 100,000 per year in men and 2.7 to 3.3 cases per 100,000 a year in women. Most cases are mild. Moderate to severe forms account for 5 to 6% of cases only, but it does have an impact on quality of life, even with mild disease. And it also is a significant public health burden in terms of direct and indirect costs. And it can be really challenging, especially to manage, especially the moderate to severe forms, which are often unresponsive to available medical treatments. In terms of the clinical activity score, this is just a reminder how we score for activity, because it's going to come up a lot in the paper. So they use a 7-point score. We score 1 point for each of these components, and CAS below 3 means inactive disease. CAS still the active. In terms of patient of severity, according to the UGO guidelines, we have mild, moderate to severe, and side-threatening disease. So patients with mild disease have only minor impact on their daily activities, so insufficient to justify immunomodulation or surgery. So it's a minor lid retraction, less than 2 millimeters, mild soft tissue involvement, mild exophthalmos, less than 3 millimeters, and no or intermittent diplopia. Whereas people with moderate to severe disease have lid retraction more than 2 millimeters. They have moderate to severe soft tissue involvement, exophthalmos greater than 3, and inconstant or constant diplopia. And in that case, we would consider immunosuppression or surgical intervention. And start threatening very severe GO are patients with optic neuropathy and or corneal breakdown. Before I proceed to the paper, I'd like to summarize what's the clinical practice today. So this was published a few weeks ago, and the European Group on Graves Orbitopathy appointed a task force to review the guidelines from 2016 in order to include the new so in summary, the recommendation is first of all, so refrain from smoking, treat thyroid disease, refer to eye clinic if risk factors are present, such as active disease, a smoker, high receptor antibodies, or unstable or severe hyperthyroidism. Management is local treatment and systemic assessment. And only if quality of life is markedly impaired, then we can discuss low-dose immunomodulatory agent or rehabilitative surgery once GO is inactive. For moderate to severe GO, the recommendation is first-line treatment steroids to start with 0.5 gram intravenous methylpred per week for 6 weeks, and mycophenolate sodium, 0.72 grams per day for 6 weeks. If no response, proceed to second-line treatments. If there is a response or partial response, then proceed to 0.25 grams of methylpred per week for 6 weeks, plus mycophenolate, same dose for 18 weeks. And if there's a response, we stop therapy. You could also go down the route on the right where there's no mycophenolate essentially, so 0.75 grams methylpred per 6 weeks. If there's no response, second line treatment. If there is a response, we carry on with half a gram per week for another 6 weeks. And if there is a response, stop therapy. In terms of the second line treatment for moderate to severe disease, these are the options. So intravenous methylpred, oral pred, with or without cyclosporin or azathioprine, or with radiotherapy with oral or IV glucocorticoids. That's where teprotumumab was added, there along with rituximab and tocilizumab.
Sorry to interrupt.
Yeah, go on.
And
So,
then
mycophenolate, is that on our protocol?
Yes.
So,
I mean, we
methylpred.
No, we're not doing
Because
that.
I
We're
was
just
only
doing
methylpred.
No, after her friend, Vicky Lee gives them mycophenolate. If it gets worse, she said
But this is a first line. They've got me. Is mycophenolate first line on your slide?
It is.
Whereas brass isn't.
It is. We try methylpred 500 first,
Yeah.
and then Vicky's given the
12
mycophenolate.
weeks.
Yeah.
We did a pred for 12 weeks.
We
So
do.
there's a discrepancy here. Oh,
There is. I
you
mean,
haven't
look,
changed.
They're more aggressive. This is 2 weeks ago.
This has just come out, these guidelines.
Okay,
yeah,
thank you.
yeah. And then, second line, and then site-threatening GO, 0.5 gram on 3 consecutive or alternate days, monitoring of ophthalmic parameters, and then after there's no response, urgent orbital decompression surgery. If there is a response, further, we carry on further with intravenous methylpred for another week. If there is a response, carry on for with half a gram. Cumulative dose less than 8 grams per cycle. If no response, again, urgent orbital decompression surgery. And now a little bit of background on teprotumumab and how it works. So in TED, basically this shows the pathophysiology where the IGF receptor is overexpressed in the geoorbital fibroblast and lymphocytes. This is the autoantibody. This is the TSH receptor and the TSH autoantibody, and they form a complex which mediates TSH receptor signaling and augments inflammation. The human monoclonal antibody, which IGF-1 receptor, the extracellular portion, and blocks its activation. So it basically disrupts this complex. And also, it also leads to internalization of the receptor. So it could basically lead to up to 95% reduction of accessible receptor on the cell surface. So the aim of this paper, which was published in Lancet, was to evaluate the short and long-term response to teprotumumab from these 2 trials. They mainly focused on proptosis and diplopia. This is the phase 2 published in 2017. And this is the phase 3, 2020. They have very similar design. There are some differences I'm going to mention, mainly in terms of the follow-up. But the treatment phase is identical. And there is also some differences in the outcomes, but we'll go into that. So in terms of the subgroups and methods, as we said, in total, they had 28 centers from Europe and America. And they recruited patients from joint thyroid eye clinics. Inclusion criteria for study 1, the phase 2, 18 to 75 years old, a little bit older in study 2, the phase 3 trial. It was a recent onset thyroid eye disease, so less than 9 months, and active, so CAS was 4 or greater than 4. They excluded the patients who had medical or surgical treatment for thyroid eye. They allowed patients who had methylpred, but less than 1 gram cumulative dose, and they had to have a 6-week washout before enrollment. And this is their flow chart. So on the left is their phase 2, right is the phase 3 trial, and they ended up randomizing. So the pooled data is 85 to placebo, 84 to teprotumumab, and 8 discontinued from each group for various reasons. I'll mention the series of adverse events later. And they had a fairly good, despite discontinuations of completion rate, 79 and 76. And this is the design of the study. So screening randomization, and they had a total of 8 infusions. Each infusion was 3 weeks apart from the next one. Placebo, obviously the same. So the first period was 24 weeks. The last period was week 21. And then there was a visit at week 24. These are the separate endpoints of the separate trials. So phase 2 was overall response, which was defined as 2 or more millimeters improvement in proptosis and 2 or more points in CAS. Whereas the phase 3 trial had 2 or more millimeters improvement in proptosis only. And then there was an extended follow-up period, and there were some outcomes there, which I'm going to show later. So the main outcomes, the primary outcome of this analysis was proptosis response, week 24. So how they defined that, they said 2 or greater than 2 millimeters improvement in the study eye without similar deterioration in the other eye. And that was their primary outcome. And then secondary outcomes was subjective diplopia, overall response, which was reduction in proptosis by 2 or more millimeters and reduction in CAS by 2 points. 3 was disease inactivation. And they also looked at some other secondary endpoints, such as main change in proptosis, change from baseline to week 24 in the quality of life score, so total visual and appearance. That was also one of the secondary outcomes. They also did a lot of statistical analysis in depth, very complex, and they also stratified people. So they looked separately whether someone was a smoker or not, whether they were older than 65 or younger than 65, according to sex, time to diagnosis of Graves' disease or thyroid eye disease. So they have those 2 cutoffs. According to CAS levels and according to TBII concentrations, so antithyroid receptor antibody concentration, less than 10 or more than 10. They also recorded each individual proptosis response and also numbers to treat for each outcome, not numbers needed to treat, sorry. And they also had this composite ophthalmic outcome, which was mainly for the follow-up study. So they're looking for absence of eyelid swelling, CAS by at least 2 points, proptosis improvement by at least 2 millimeters, lid aperture by at least 2 millimeters, diplopia, and improvement of 8 degrees of global motility. So this, all of those were a composite ophthalmic outcome for the follow-up period, not the main trial.
Kleopatra, do you want to explain how they measured the improvements in proptosis? So what does 2 millimeter mean?
This was all clinical, so they didn't have any imaging. It was by examination.
You use something like Excel thermometry with gauge, and but it's very variable. You know, I could give my gauge to the next person to get 2 millimeters difference. That's one of my main critiques of this study.
Exactly.
Yeah, is that it's not radiological. We actually do a lot of radiological measurements of proptosis. Actually, one of our BSc students presented this year that we can measure it radiologically, and that's one of the things that we actually queried. You know, but the point is because of this nature of a multi-center trial is that because of the imaging, it's very difficult to standardize imaging even across 2 trusts. So you can imagine trying to standardize it across all the so it is very woolly. It's also like the motility. Clear, yeah. There's also motility. It's like a grade, like they're presumably using a modified Borman score in terms of it's completely subjective. The 8 degrees of movement, it's just that I'm very dubious whether that the 6th criteria is actually used in a lot of centers because it's very difficult to measure the degrees of reductions. And I couldn't see on the paper that, you know, I think it's a flush generally. Yeah, as well. Sorry, Cleo.
So there'll be a lot of inter-individual variability.
Yeah, absolutely. Proptosis certainly was that kind of measurement. Diplopia, exactly, unless they're using the actual ductions of the eyes, but it's very, very difficult to measure that. And I'll be amazed that they actually did it. I can't see any convincing evidence it was actually done, but I may be unfair. But you know, we do a fairly detailed ocular motility of patients. Our optometrists don't do it because it takes so much time. But you know, I would love to see their sub-analysis data on motility measurements if such exists. Sorry, Cleo. Yeah, thanks.
No, thank you. In terms of the follow-up I mentioned, so they examined proptosis and diplopia at minimum 7 and 51 weeks after the last infusion. So that would be week 28 and week 72. Obviously, two studies, they were a little bit different. So study one had only week 28 and week 72 visits, whereas study two had more irregular intervals, as you can see here. And now, in terms of patients who were not followed up for any reason, they were assessed at the last visit for proptosis, diplopia, and composite outcomes. People missing data for one or more visits, again, were assessed at the last. And patients who had to receive medical or surgical treatment were considered non-responders. In terms of statistical analysis, all the analysis was done on numbers intended to treat. So all patients who were randomly assigned to have placebo or teprotumumab, they were all included in the analysis, even if they had to withdraw. And they did this stratification model, so it was by study 1 or 2, and then tobacco use. And they estimated a stratified difference. So that was the difference in response between teprotumumab and placebo, but it was weighted according to those strata. So study 1, 2, tobacco, no, yes, and it was this sort of quite sophisticated statistical analysis for the primary outcomes, essentially. In terms of demographics, sorry, this is very small, but essentially both groups were very well matched. So nothing really stood out from here, both teprotumumab and placebo. And then in terms of results, so this is the proptosis results. So this is the primary outcome. And as you can see here, 77% of patients in the teprotumumab group had a response at 24 weeks versus 15 in placebo, and this was statistically significant. So this is more than 2 millimeters. And in the study eye with no deterioration in the other eye. This graph B shows nicely the change from baseline over time. And again, week 24 minus 3.14 and significantly greater than placebo. And then the bottom graph shows the mean reduction. So basically the worse baseline people had, the more benefit. So mean reduction was 3.7 in the group on the left, which had the worst baseline, and mean reduction was 2.8 in this group, which they had lower baseline proptosis. Numbers needed to treat were good, was 1 in 6 for proptosis. In terms of diplopia, which was the secondary outcome, so this is the responders graph A, so 1 or more grades of improvement. So we can see again, week 24, 70% of the teprotumumab group responded as opposed to 31 in placebo. This was statistically significant. And 53% had complete resolution at week 24. In terms of, this shows the grade of improvement, so intermittent, inconstant, and constant. So from all these numbers, only the constant diplopia, 71% of teprotumumab was significantly better than placebo. So numerically looks better in the teprotumumab group, but only this one, the 71%, was statistically significant. And again, so numbers needed to treat, again, really good, 2 in 5 for diplopia. In terms of the other secondary outcomes, this was the overall response, which is proptosis 2 or more and CAS 2 or more. So 24 weeks, 74% of the teprotumumab had responded, which was statistically significant compared to placebo. Again, they show the change from baseline over time, teprotumumab blue versus placebo gray. Graph C looks at each component of the CAS and their response at week 24, and it was all significantly better than a placebo. I think the most impressive was the spontaneous orbital pain. So 90% of the teprotumumab patients had resolution, and also the gaze drop pain, 87%. So all quite impressive, highly erythema, complete resolution. And then the D is disease inactivation. So these people ended up with CAS 0 or 1. So this was 62% of the teprotumumab, significantly higher than placebo. And then these are some subgroup analysis. So I mentioned these subgroups at the beginning, where it was the age cutoff, the tobacco user or non-user, time of diagnosis of thyroid eye disease, of Graves disease, task force, and anti-TSH receptor antibodies. So essentially, in terms of proptosis, there was significant difference in the teprotumumab group in all the subgroups. So however you analyze the data, the difference remained significant compared to placebo. In terms of diplopia, the only one which wasn't was the smokers. So the smokers, so the difference between teprotumumab and placebo in the smoker group was not significant for diplopia. And if you look at people with less than 10 baseline TSH receptor antibodies, only this subgroup, again, it didn't reach statistical significance. They also did a post hoc analysis, again, according to baseline TSH receptor antibodies. So this was based on Douglas et al. So this was the study 2. So they looked at proptosis at 24 weeks, overall response 24 weeks, disease inactivity, change in proptosis from baseline, and change in diplopia responder at 24 weeks. And essentially what they showed was there's no difference either between the two groups, between high and low titer of TSH receptor antibodies. So there was no difference in response. Teprotumumab had a better response compared to placebo. I'd like to show that although there was no imaging overall, there was 6 patients in one center in the United States that was for phase 3 trial. So these 6 patients had MRIs. So these are the clinical photographs. So A is the placebo, baseline week 24. B is the teprotumumab, baseline and week 24. So it looks quite impressive. And in terms of the MRI, baseline on the left, you can see the orbital fat and the inferior rectus muscle and how they have shrunk, so a decrease in volume after 24 weeks of teprotumumab. In terms of quality, so this is quality of life questionnaires. Again, teprotumumab was had significantly better scores than placebo, so increased by 19 points in the total score, increased by 19.7 points in visual functioning, and 17.7 in appearance. And these are the responses during the long-term follow-up. So 7 weeks after the last infusion, week 28, you can see that 87% of the patients were still responders. And even week 72, which is more than a year, it was again 67%. In terms of diplopia, week 28, 66% remained responders, and 69% were responders at week 72. So weeks 28 and 72 have most patients because study 1 didn't have the interim visits. The composite ophthalmic outcomes, 92% were responders at week 28 and 83 at week 72. And also the quality of life scores did not improve but did not deteriorate, so they maintained their response essentially. Now, in terms of adverse events, so teprotumumab, they had 7 serious adverse events. 3 of them were deemed to be relevant or related to teprotumumab. One was infusion site reaction. The other one, and that led to discontinuation. The other one was Hashimoto encephalopathy, again led to discontinuation. And the other one was diarrhea. But they had 2 serious cases of diarrhea, but one had a background of UC already, and the other patient again had some issues, I think had a bowel resection. In terms of the other one, so hearing impairment was quite common, 10%. They didn't speculate on the mechanism. Hyperglycemia, again 10%, and muscle spasms, which were mild. So they only had basically to withdraw these 3 patients I mentioned. In terms of the strengths, this is one of the largest control study reported to date in patients with thyroid eye disease. And they provided insight into both short-term and long-term efficacy and safety. It's clinically relevant as they focus on proptosis and diplopia, which can be resistant to medical therapy. They showed that efficacy maintenance nearly 1 year after discontinuation of the drug. Also shown in all the population basis that the efficacy is independent of age, disease duration. They show that it is associated with an improvement in quality of life as assessed by the questionnaire, the GoPal scores. And the adverse events were transient, and there were no new events during the follow-up period. In terms of limitations, obviously they combined 2 studies, so there were less patients up until week 72, so there were no interim visits in study 1. Also, the non-responders, they were enrolled in an open label trial, so there was no sort of follow-up study. They missed some patients from the long-term follow-up. And also the patients included were patients with progressive active disease, so CAS was 4 and more, and also recent diagnosed people with Graves Orbitopathy. So we don't really know about the sort of chronic patients and what would be the efficacy there. And so they concluded that teprotumumab selectively targets the IGF-1 receptor, and it could be a substantially modifying agent for the clinical course of thyroid eye disease. Thank you.